Joyce, for that kind introduction. It's really my delight to be here to speak with you this morning about hospital-associated venous thromboembolism as it pertains to the pediatric population. And these represent my disclosures. I'd also only say that given the speakers that are following me, if you need to step out, answer a page, grab a cup of coffee, do it during this first portion. You'll tend to miss less. So what I'd like to do over these next 15 minutes or so is review with you the epidemiology of hospital-associated VTE in children. Talk about how the incidence and prevalence of this disease has evolved and emerged. Discuss risk factors that have been identified to date and what we know and really admittedly what we don't know about the evolution and adoption of formalized risk assessment models. I'll close by sharing with you some of our experiences in the adult population and bending the curve on hospital-associated VTE prophylaxis within Intermountain healthcare. So I'll start by saying that broadly speaking, compared with adults, hospital-associated venous thromboembolism in children is rare. If we look at community-based data, VTE seems to occur somewhere between 7 and 14 cases per million. Once children are hospitalized, though, that number climbs, and historical data suggests it approaches about 5 to, as we'll discuss more, per 10,000. Hospital-associated VTE in kids does not occur in a vacuum. In fact, over 60% of children that develop thrombosis have at least one coexisting chronic complex medical condition. And this is an important disease because VTE-specific mortality in pediatrics could be as high as 2%. Interestingly, up to 20% of children that develop venous thromboembolism in fact present with pulmonary embolism, and in that cohort, VTE and PE-specific mortality may be as high as 10%. Well, if we look at the costs associated with thrombosis in the hospital, they are tremendous. Every year, about $2.5 billion is attributed to hospital-associated preventable venous thromboembolism. And in medically ill adults, it's thought to about double the expense directly attributable to a hospitalization. Interestingly, you'll see that the expense attributed to hospital-associated VTE in adults does not differ so much from kids, adding about $26,000 to a given admission. And I would submit to you that one of the tragic complications and costs of deep vein thrombosis in the pediatric population is post-thrombotic syndrome. This is characterized as chronic pain, swelling, tenseness, fullness, heaviness of the affected limb. And given the age at which kids develop thrombosis, why these complications can persist for 5, 6, 7 decades. One of the great challenges associated with tackling hospital-associated venous thromboembolism is the heterogeneity of the population that is being studied. Evidence exists that risk factors vary, even based upon age group, differing between neonates, those that are 1 month to 1 year, younger children, and teenagers. The highest incidence of VTE appears to occur in neonates, and then there's another peak in adolescents. Part of that, we think, is a function of how well you're all doing in keeping these littlest babies alive and the intensive medicine, including catheters, that need to be used in that population. In the adolescent peak, we think that it's largely attributed to hormones in addition to trauma. It's likely also that risk factors vary not only by age, but additionally by the service line, differing among kids in the coronary care unit, the ICU, those on the oncology service, trauma, and the medical service. So a heterogeneous population introduces a challenge that is perhaps unique to pediatric VTE. What we do know is that regardless of patient age, we're seeing an increase in the incidence, that is to say number of event rates over a time, in this case a year, across the board. This often quoted study, which looked at over 11,000 discharges from 40 children's hospitals between 2001 and 2007, demonstrated that the rate of venous thromboembolism associated with hospitalization climbed from a baseline of 34 to 58 cases per 10,000 admissions. And if we look at risk factors for hospital-associated venous thrombosis, while first and perhaps best described among adults, we know there's a lot of overlap with the pediatric population. Interestingly, some of these risk factors seem to perhaps be more pediatric specific, and others are well described in adults, and yet some uncertainty exists regarding how they influence thrombosis in children. One of the salient risk factors that'll be a meaningful portion of the next talk, and I think is worth a slide all to itself, is that attributable to central venous catheters. More than 5 million central catheters are placed in pediatrics annually, and most thrombosis that occurs in children, in fact, is related to an indwelling central venous catheter. Among neonates, somewhere between 60 to 90% of thromboembolic events are catheter associated, and this really represents the most common acquired risk factor for thromboembolism. Arguably a terrific place to look to try to bend the curve on thromboembolic disease. Well, in addition to central venous catheters, other risk factors have been described. Mahadrin and colleagues did a very nice job performing a systematic review and meta-analysis to try to better inform what we understand about risk factors across the course of these data. In this meta-analysis, they identified 7 studies that looked at the effect of central venous catheters, over 3,000 cases, 600,000 controls, and identified an odds of thrombosis attributable to catheters of just over 2. Similarly, intensive care unit admission, mechanical ventilation, and prolonged length of stay were all associated with increasing risk for hospital-associated venous thromboembolism, as you see here. While identifying risk factors may be one part of the challenge, the other part, I would suggest, is putting it all together. And to do that, risk assessment models have been derived and developed to inform how we can look at an individual patient and understand their risk for thrombosis. This is the simplest RAM I could find a cartoon of, and this really highlights an important aspect of a risk assessment model. You want it to be simple. In pediatrics, I would characterize the literature regarding risk assessment models as emerging. In fact, there are only 4 risk assessment models that have been described to date, and so I'd like to flip through those with you now. The first was one described by Prentice and colleagues, where they performed manual chart review of 1,000 charts. There were 20 hospital-associated VTE events. 18 of those 20, importantly, were in teenagers, whereas greater than 50% of their controls in that study were less than 5 years old. They identified a positive correlation between a 3-tiered risk score and hospital-associated VTE. However, they did not provide details regarding which risk factors made it into that score and what value or weight, if you will, was placed on each risk factor. Interestingly, they did identify female gender as being a risk for thrombosis. Admittedly, in the analysis, there was a significantly greater portion of patients that were female in this study. Branchford and colleagues did a nice retrospective electronic chart interrogation using ICD-9 codes to identify 78 cases, and then they matched those cases to hospital-associated VTE in a 1-to-2 fashion, using first univariate and then multivariate logistic regression, which is the process that was used in the subsequent risk scores I'm going to talk about. They identified 3 risk factors: mechanical ventilation, infection, and prolonged hospitalization as having an increased odds for thrombosis, as you see here. And they described that among those patients that had all 3, the rate of hospital-associated VTE was about 3%. Atchison took it one step further in their retrospective case control study. They found 50 cases and then matched them in a 1 to 7 fashion to controls based on age, gender, service line, and found that, again, central venous catheterization, infection, and a prolonged hospital stay were associated with an increased odds of thrombosis. They then assigned relative points to these risk factors and derived an 8-point score. Patients that achieved 8 points had a 12.5% rate of hospital-associated VTE, 7 points, just over 1%, and less than or equal to 6 points, a very low rate of venous thromboembolism. Chirac Thumar and colleagues describe the pediatric clot decision rule, or PCDR, and this is probably the most advanced derivation of a risk score that's been performed to date. They identified in Indiana 173 cases of thrombosis initially upon EMR interrogation, then chart review, and found 346 controls. Their colleagues at the Children's Hospital in Chicago served as a validation set, identifying 100 patients that served as their cases and then 100 controls. The mean age of the children in the derivation cohort was just over 7 years. A third of them were newborns, and this is the distribution of venous thromboembolism that they saw. These represent the risk factors that they identified upon logistic regression as having significant odds for hospital-associated thrombosis, and they assigned the points as you see here. This work led them to generating a predictive receiver operating characteristic curve with an area under the curve of 0.85, and among patients that had a risk score of 3, the rate of hospital-associated VTE was just about 2.5%. So now that we have identified a handful of risk assessment rules, are we ready for prime time? Should we go ahead and adopt these in clinical practice? Well, methodologists have suggested that there's a hierarchy of evidence that we should use in deciding whether to adopt a clinical decision rule into routine practice. Level 4 evidence is that which needs further evaluation. It's characterized by studies that have not validated or been validated only in split samples, large retrospective studies. Levels 3 and 2 evidence, as you can see, are associated with improving the quality of evidence that we see in deriving and then validating risk assessment models. And what we're really shooting for is a derivation and validation that occurs in at least one prospective setting among different populations. And it's in this case that we can feel confident that we can adopt the clinical decision rule, in our case, why a risk assessment for hospital-associated VTE. I would submit to you that presently in the pediatric literature, the level of evidence that exists for risk assessment model adoption is level 4, which suggests that there's a lot of opportunity here for future research. I've highlighted some of the challenges associated with pediatric venous thromboembolism mitigation. The thrombosis risk varies across these age groups, and with the prevalence being lower in children than adults, there's perhaps a finer balance between the risk attributable to thrombosis, but then the risk associated with anything we would do to mitigate that, such as chemoprophylaxis, where bleeding inevitably needs to be taken into consideration. Evidence is lacking surrounding an optimal chemoprophylaxis risk assessment tool, optimal drug and dosing for chemoprophylaxis, and the establishment of a validated risk assessment model. So I'm going to close by touching on some of our efforts in the adult population to affect optimal thromboprophylaxis in the hospitalized medical patient. In a prospective cohort study, we first obtained signed informed consent from all of our hospitalists, and then over a 3-year period, control, intervention, and subsequent year, identified each patient that was admitted to the medical service as being at high risk for thrombosis or not, We interrogated the electronic medical record to see if those patients were receiving what would be characterized as appropriate chemoprophylaxis. And then if they were not, we sent a text page every morning at 9 a.m. to the hospitalist of record, alerting them that they, number one, had a patient that was perhaps at high risk for thrombosis, and number two, were not receiving appropriate chemoprophylaxis. The intervention was really three-pronged. It consisted of first that alert that I described, but then every month we fed back to each individual hospitalist their performance regarding optimal thromboprophylaxis as compared to that of their peers in a de-identified fashion. And each hospitalist over the course of the year completed a number of CME training modules. This figure demonstrates our observation of hospitalist performance over 2010, 2011, and 2012 in the gray, blue, and green bars respectively, with each letter representing an individual hospitalist. What we saw was that the rate of appropriate chemoprophylaxis combined climbed significantly from the baseline year, the intervention year, and the subsequent year in follow-up. We also observed an overall reduction in hospital-associated VTE, and the Intermountain Thrombosis Research Group, in fact, was awarded the 2015 Centers for Disease Control and Prevention VTE Reduction Champion Award for that. So I'll close by touching on next steps as I see them. First, I think we really require multi-center collaboration to move the level of evidence forward surrounding what we know about hospital-associated VTE and affecting the incidence of this disease. Routine standardization of the definitions of risk factors will be central to being able to collaborate in a multi-center fashion. And we should prioritize clinically important outcomes, perhaps as opposed to radiographic outcomes that have uncertain clinical significance. Lastly, why I would suggest that we need to emphasize the variance in risk factors and their effects based on age and service line, because by having this information, we'll know how to optimize any intervention that we provide. So with that, I'm going to step aside and turn the microphone over to Dr. Miller. Thank you.
All right. First of all, I want to thank Dr. Scott Woller for coming and presenting this topic with us. This has been one of those topics that I think for a long time people have really thought was an adult issue and not really a pediatric issue, but it's certainly something that we've been seeing increasing over the last few years. I know I've been a hospitalist now for about 10 years, and this is something we hardly ever talked about way back when, about 10 years ago, and now it seems to be something that we're seeing much more common, particularly on the hospitalist service. The other thing, the other reason for doing this is, one, again, to increase attention to this, as well as what Primary Children's is doing to help reduce our number of hospital-acquired venous thromboembolisms. I'm going to specifically talk about the catheter-related ones, and this one actually came important. I think I was on service over the summer, and we had a young lady who was admitted to the hospital. She had a PICC line in. One day on rounds, we noticed that her arm was red and swollen, and so we decided to get the ultrasound. The ultrasound showed that she had a clot. And so I was talking to the team about, well, now it looks like she's developed this clot from her PICC line, and this will, in a sense, count against us for the hospital-acquired conditions group for VTE. And the one thing that came out of the residents was this feeling of hopelessness from the standpoint of, they were like, well, how are we supposed to prevent these? Like, we talk about all the other VTEs, like we get people out of bed, we get them SCDs, we can, do different things, but like, how as a physician can I control whether or not somebody gets a clot from their their pick. And so hopefully a few of the efforts that we're going to talk about today will help to curb that and give people a sense that, yes, we actually can do something about catheter or central venous catheter-related VTEs. So first of all, what I wanted to talk about is the Children's Hospital Solutions for Patient Safety. This is a hospital collaborative of approximately 130 hospitals across the United States and Canada. We joined this group back in 2011, right when we started our journey down sort of to zero harm. The objective for this group is one that's important, where they collect and share data to learn about hospital-acquired conditions that cause harm to hospitalized children. So not only do we report our data for our venous thromboembolisms, but we also share data on our central line-associated bloodstream infections, our catheter-associated urinary tract infections, falls, a whole variety of hospital-acquired conditions. We all share our data so we can all learn together. The mission of this group is working together to eliminate serious harm across all children's hospitals with, I think, an amazing vision of all kids, all hospitals, all safe. So as I mentioned, we did join them in 2011. As far as the VTE portion of this, we started in the, I want to say the fall of 2017, and have been working on this ever since. The other aspect of, from the VTE perspective, other hospitals have been actually working on this for 5 years, so we are a little bit behind the curve when it comes to venous thromboembolism. So first of all, I think anytime you talk about hospital-acquired conditions, and you need to talk about, so what is a venous thromboembolism, as well as what is the inclusion and exclusion criteria, so we know we're all on the same page. So for venous thromboembolism, the operational definition that we've been using is it's a condition where a blood clot forms within a deep vein and may compromise blood flow to that area, or may actually embolize or cut loose and go to the lung, causing a pulmonary embolism. When you refer to pulmonary embolisms, you're specifically talking about obstructed pulmonary arteries that can result in life-threatening decreased oxygenation of the blood. So that was at least, that's what we needed to have happen first to characterize a VTE. Secondly, the inclusion criteria for any of the VTE events is, one, we counted any clot within a deep vein, any PE, any intracardiac clot, so any clot in any 4 chambers of the heart are counted, any clot within the cerebral venous or cerebral sinus veins, and then any clot related to fistulas, grafts, central venous catheters, or other prosthetic materials, which is obviously a big one for us. The interesting thing that I think that gets a lot of people as well is that we think hospital acquired. So there's a little bit of a timeline that goes with this. So this is any VT event that meets the criteria above, so any of these criteria, but can occur within 1 week of hospital discharge. So once we get them out the door, it's not like, whew, we're safe. This kid's good to go. We actually have to follow them for about the next week to see if they subsequently develop a venous thromboembolism. And then the other thing to keep in mind is if you're having a horrible 3-day period and you end up with multiple clots in multiple areas during this 3-day period, they all count as one. So I guess potentially that's good for the bean counters, but not so good for the patient. All right, so when we start talking about deep veins, everybody's always wanting to know what do you classify as a deep vein? I don't know if anybody's looked at actual ultrasounds and there's veins and they talk about veins and one's clotted and which ones aren't clotted, and always trying to determine which ones. So when it comes to arm vein terminology, the big ones that we worry about would be the radial and ulnar veins, the brachial, axillary, and subclavian veins. We don't worry as much about the cephalic, basilic, and the cubital veins. Those are considered superficial. When it comes to the leg, basically anything but the greater and lesser saphenous is going to be considered a deep vein. So if you end up with a kid with a clot in either of the saphenous veins, those are counted as superficial. The other thing to keep in mind is that any vein that's in the, as I mentioned earlier, in your head, in your chest, or in your abdomen, those all count as deep veins. So if you get a clot in any of those are automatically deep vein, which would be expected. All right. So which ones do we not count? So what's our exclusion criteria? So if the patient comes in and they've developed this prior to hospital admission, and this is based on the excellent history and physical that the people have done on admission, so the patient comes in with a limb that's red, hot, swollen, or they come into the hospital with a pulmonary embolism, and we're able to identify it within 48 hours, we consider this a quote-unquote community-acquired VTE as opposed to hospital-acquired. Other things that will help exclude patients from this is if they have a fibrin sheath or a thrombus, it's limited to the catheter only with no venous extension. So if you just have a clot on the end of your PIC, that doesn't count, but if there's extension into the actual vein, that does. We also don't count venous narrowing, stenosis, or scarring, post-thrombotic syndrome, as Dr. Woller mentioned. Chronic clot doesn't count, and this is actually a big component for our oncology patients, since a lot of them will come in with chronic clot. So every time they come in, that's not considered a new event. If we know they have a VTE and it extends, that doesn't count as an additional event. That's still all just one. As mentioned earlier, we don't count superficial veins, and we don't count arterial clots. And then finally, clots originating within externalized mechanical cardiopulmonary circulation. So patients who are on ECMO, cardiopulmonary bypass, or an LVAD circuit also don't count in that group. So here's where we're at. When you look at the SPS network this is the venous thromboembolism event rate. As mentioned earlier, pretty much everybody else but us has been doing this for about the last 5 years. Their overall baseline rate is at 0.4. VTE events per 1,000 days. As you can see, there's about 60 to 70 hospitals that are providing information into this. And as you can see in the graph here, this is the dates down here with the VTE events per 1,000 patient days up here. Just hot off the presses, we're at a whopping 0.78 VTE events per 1,000 patient days. So we certainly have some room to improve things and to hopefully achieve closer to these numbers. As far as the actual raw data in a sense, for the year of 2017, we've had a total of 52 VTE events. As you can see, 41 of them were related to central venous catheters, which accounts for 79%, which does, I guess, validate Dr. Woller's data that says 60 to 90% of pediatric VTEs are caused by CVCs, or we validated him or he validated us, one of the two. And then the other groups that we saw are the non-CVC. So this is the group who don't have any central venous catheters. They just ultimately end up with a clot, and that was 8 in the greater than or equal to 12-year age range, and then finally the less than 12-year age group, giving a whopping 3 in the last year. So the other thing I think that always comes up is when you talk about central venous catheters, everybody always wants to know, like, what exactly do you mean? Does this catheter count? Does this one? Like, what exactly do you mean? So the criteria that we're using is that if the access or insertion site goes into a deep vein, no matter where the tip ends, it's automatically a central venous catheter, right? So if you go straight into the subclavian vein, it doesn't matter, like you're gonna be in a deep vein. The next one being, so non-central catheters or midlines only get counted if the tip or the access point is in a deep vein. So there has to be some communication with the deep system. And then finally, we all keep in mind all types of vascular catheters should be counted. So this is the implanted ports, your tunneled catheters, so your Broviacs and your Hickmans count, and then your non-tunneled, particularly for us, the non-tunneled central venous catheters with the tip location in a deep vein. This is a huge group for us, right? This is the PICC lines, this is apheresis catheters, dialysis catheters, but really, I would say this group here is the big one for us, is because again it's the PICC group. And then finally, the other one that always comes up that gets people a little bit anxious too is the procedures that require temporary placement of a catheter. So this is your patients who have the catheter that's used for a cardiac catheterization. So if you develop a clot after a cardiac catheterization, that would also count for a CVC related VTE. So ultimately, as I mentioned before, everybody's like, how do we actually improve this, right? The patient needs the central venous catheter, but how do we keep them from getting clots? And so part of joining the SPS network was to figure out how we can improve this. And as anybody knows, anytime you have hospital-acquired conditions, there's always a bundle, right? That if we adhere to the bundle, we will drop our hospital-acquired conditions. So here is the CVC bundle. I know you guys are excited. So our global aim for SPS in general is to eliminate serious harm due to VTE in all children's hospitals. So if we can eliminate the harm, we're good to go. But our actual goal here locally in all the other hospitals is to reduce CVC related VTEs by 40% per 1,000 CVC line days by December 31st of 2018. So that's our goal. That's what we want to reach by December. We had some key drivers that will help us to reach that smart AIM, and then finally the big key is the intervention piece. Like, what can we actually do to prevent this from happening? So the three factors for the CVC bundle are, first of all, you look at the line size selection. So it's important to have the catheter, the outer diameter of the catheter to vein ratio to be less than 0.5%, or less than 50%, or less than 0.5. It makes sense because the bigger the catheter, the more likely you're going to occlude that vein, which is going to increase stasis. So you want that ratio to be less than 50% to allow plenty of blood flow around that catheter. And this is, you take the outer diameter and you measure it with the point of the vein entry without using a tourniquet. Because obviously if you use a tourniquet, you're going to enlarge that vein and you're going to artificially create a bigger vein. And the other important piece of this is to use an ultrasound when determining the size of the catheter. The next one is to limit the number of CVC insertion attempts, where you want to keep 2 or fewer pokes, or essentially skin entries into that region, because it's well known that the more times you poke the area, you're going to lead to endothelial damage, which is going to lead to more clot formation in that area. And then finally, the ideal CVC tip location. This doesn't seem to be much of a problem. It seems like a no-brainer, but this is basically making sure that the tip of the CVC ends where it's supposed to, and that the location is verified by imaging. So for lines originating above the diaphragm, they should end in the distal superior vena cava or in the superior vena cava right atrial junction. And for lines below the diaphragm, they should end in the inferior vena cava. So obviously, we was like, well, how exactly do we roll this out to the hospital? So we met in August, or this summer, August of 2017. We met with our IV team to see if they would be willing to take on this project. And I have to say that they graciously accepted, and they have gone full bore and have embraced this and have gotten us where we needed to be. And so it was a lot of the hard work for the IV team to change their workflow and to actually implement all 3 of these. But as I mentioned, we wouldn't be where we're at without their help. So here's actually how we've done when it comes to the CVC bundle with the IV team pilot. So as you can see in August of 2017, and our overall goal is to get to 80% compliance. Our catheter to vein ratio was at 60%. Our number of pokes was at 100. Our IV team does an excellent job of not over poking people. And our tip placement, we weren't really sure how we were doing. Since implementation of the bundle, we can see that we were able to get, by January 2018, the 80% of our catheter to vein ratio. We reached that goal, as well as the number of pokes, and then tip placement accuracy was at 87%. So in just a few short months, our IV team has actually been able to get us completely compliant on this particular bundle, and we're very proud of all the hard work that they've done to improve this system. All right, so where are we actually at so what I showed you before was the overall rate. This is where we're at for the actual CVC event rate. Again, this is the network in general. Down here, you've got just for each month. Here are the CVC events per 1,000 line days. For the most part, they average about 0.8 to 1.37 events per 1,000 line days as a whole. And then here is where we are primary children's. This graph is interesting from the standpoint. So here's the dates down here. On the right-hand side is the overall number of CVCs. So the blue bars is the overall number of CVCs, and then this is our rate, as you can see here. So similar to the overall rate, we also have some work to do because we're quite above the 1.1, particularly as you can see in September, we hit a all-time high of like a little over 2.5, so certainly a lot of work. And I think the other thing to point out here is, while we can sit here and look at these fancy graphs and everything, each one of these patients, each one of these markers in this bar is actually a patient that we've essentially harmed by causing a VTE in them. So I think that's the other big thing to keep in mind, that we can kind of look at graphs all day, but these are patients that came into our hospital. They got a central line, they got a VTE, and as Dr. Woller mentioned, increased cost, increased potential complications, needed blood thinners. This is certainly something that we did to them. And so that's, I think, always the other piece to sort of keep in mind when you're looking at this. Finally, so where are we at? So currently we've met our CVC bundle requirements with assistance of the IV team. Like you mentioned, they've done a phenomenal job of helping with this. The next steps is going to be the summer of 2018. We're going to expand the CVC bundle hopefully to the pediatric ICU and the cardiac ICU. And then finally, the fall of 2018, expand the hospital-wide to include interventional radiology and essentially everyone else, so that hopefully we can reach the goal that everybody else has achieved through their CVC bundle. And that's all I've got. Now it's Karmella's up to talk about non-CVC. John.
Can I ask one?
Sure.
When you go back,
Mm-hmm.
when you have that.
Right. So
So that's just by your requirement there.
right. So right. As John had mentioned, the reason why we're at 80%, because as you can imagine, particularly in the NICU, you've got one size catheter. Like you don't have many options, or even in the cardiac ICU or the peds ICU, you only have so many options, and so that's why it's left at 80%. But you know, if that's your only option, then you document it and move on, and you do the best you can. So, thanks. Oh, yeah. Oops, don't start that. There we go. Right? Yep. Hopefully Word won't open up.
It'll be fine. Good morning. It's National Patient Safety Week, so I feel like we're right in sync with that in one of our hacks that we want to present today, the venous thromboembolism, probably the youngest hack at this point. All righty. So I just did a couple little calculations while Dr. Woller was speaking, and with our 52 events that we had last year and $25,000 per event, we had an additional $1,345,000 that we spent on unnecessary VTE events, with zero harm being our goal. So opportunity for cost savings, as well as protection of our patients, a safety initiative. So I just wanted to start with, first of all, dedicating this project. I've been a nurse for over 35 years, and in my experience as a nurse, the things that really took me the most by surprise were both my patients that died of venous thromboembolism events, and then a couple of my colleagues, as well as some family members. So I just wanted to really dedicate the passion for this project to two of my colleagues. One that you see on the left is Nancy Kern-Abbott. She was a nurse on the Children's Medical Surgical Unit. That's before we split and were CMU and CSU. About 15 years ago, and she passed away at 34 years old, newly married, DVT one day, pulmonary embolism the next, and she was gone. The nice thing about Nancy is, you see her with an MDI inhaler, so she is in all of our Breathing Easy asthma patient education materials, and her legacy lives on. So we teach and see Nancy every day as part of our asthma initiative. The other person is Julie Ballard, and many of you may have known her story as well. She's a respiratory therapist that was very engaged in many respiratory initiatives, very thorough in the data analysis of things as well. Julie was scuba diving about 7 years ago and had a VTE event and passed as well. So this is dedicated to my colleagues as well as patients. I have one objective, and that's really to summarize all of the non-CVC, that 20% of the VTE that we see in children, some of the process that we have, some of the data, and the ongoing strategies to prevent non-CVC VTEs. And again, remind yourselves, this bundle has been going on for about 5 years in SPS, and we have just been a part of that over a year with just joining the Pioneer Collaborative that Dr. Miller spoke about in the last 6 months. So again, this is the slide with the overall network rate, 0.4. We're at 0.78, so we have almost twice that of the network. This is the non-CVC graph, network-wide. It's at 0.4, and we're about 0.2. So we have some great opportunity with the non-CVC as well. The reasons that we really need physicians to recognize the incidence and prevalence of this, again, goes back to zero harm. We really want zero harm safety events for our patients. So no longer to think of it as a known complication or something that rarely happens, but it's something that does happen and something that is preventable. So it's the second largest contributor to harm, only with hospital-acquired infections coming first, mostly CLABSI. There's about 130 to 140 total events each month in the network, and about 12 to 18 of those are the non-catheter events with patients greater than 12 years of age, and that's our greatest opportunity for improvement. Teens begin to clot like adults around puberty. It is preventable with our bundle in the OR, so looking at an initiative to put SCDs on all patients greater than or equal to 12 years that have invasive procedures greater than an hour in the OR. And then also preventable inpatient, just with basic nursing care, back to ambulating or mobility at the maximum for that patient, wearing SCDs and making sure we're keeping on the SCDs, as well as making them for patients who want to wear them and nurses to push that they can wear them and document that. And then Dr. Miller really talked about the catheter-associated VTE, and we do have a bundle at this point. This is the risk screening assessment for our non-CVC patients greater than or equal to 12 years. The screening will take place on admission, post-op, and transfer to higher levels of care. This has to do with our risk screening, so they screen at low risk or at risk. And then based on high risk or at risk, the interventions that we do are encouraging those highest degree of mobility, encouraging the SCDs for at-risk and high-risk patients. And then anticoagulation therapy is only a recommended part of the pediatric bundle. These are standard screening VTE risk factors. So as we talked about mobility, there's a baseline, and then there's actually the altered that corresponds to the Braden-Q scale. Then personal history of thrombosis, thrombophilia, critically ill. So lots of people in the critical care units would automatically screen as at risk. Any active cancer or malignancy, recent surgery in the past 30 days, and then estrogen therapy, now taking or haven't taken in the past couple of weeks. These are the recommended factors. I won't get into all of that, but certainly as you start to see some themes, obesity, immobility, hypertension, any metabolic states, those all contribute and those factors build up to be at higher risk. The nice thing about screening is that we can build it into Icentra. So it has been designed for the non-CVC part of the bundle. We just have not built it completely until we get through some of the Icentra hoops. This is an example from Children's Hospital of LA, where they took the paper screen assessment that you saw previously and they actually built it into their medical records so it screens automatically and then pops up to tell the nurse at what risk level they are at for getting venous thromboembolism. For sequential compression devices, we all know the positives. These are just a few of the problems, the contraindications, which are minimal. Just if there is already access in that foot or a suspected DVT in that leg. Certainly if there was skin conditions that would be aggravated by the SCD, if there was acute fracture, it's okay to use it in the opposite, unaffected extremity. Not having the correct size available has been the barrier for us. So currently we are trialing this year 3 pediatric specific types of SCDs with the plans to purchase next year in 2019 and implement the screening strategy because we will be able to have the equipment to accommodate the need. And then certainly in their lower extremity conditions with pain. This is another part of EMR screening that this is actually from Tennessee. They have a Cerner as well, and so they have some of the contraindications built into their system as well as a bleeding risk assessment, as well as some contraindications to pharmacological prophylaxis. So these are some of the contraindications to anticoagulation therapy. As stated before, it's a recommended part of the bundle, so we do not get into that. We just ask you assess risk and benefit and document for those patients your anticoagulation therapy. This is our non-CVC rate in the network. We're part of the blue line, so we're actually part of the hospitals not now submitting the process data on our non-CVC element. until we can build that into Icentra. Those that are submitting the process data do have a lower rate. So just pointing that out, that certainly with process, which we achieved with the CVCs, that does contribute to the outcomes. This is total number of VTE events. And what we've noticed in the network is there's been a change in January. So the green is all of our CVC-related events. And as you see, we started the CVC bundle last summer. So those achieving process data we think has really started to affect the outcome data. That first gap is a decrease in all of those CVC rates, and that's where we're seeing the biggest impact of that. So we're noticing a change. We're just waiting for a trend for that to happen over time, that we can actually show that process data has impacted our outcomes. And this is our primary children's VTE non-CVC rate per patient days. The network was at 0.04, and we're at 0.2, so we have lots of opportunity for improvement there. Again, for inpatients greater than 12 years, we want to screen people and really provide interventions for those at greatest risk. For patients greater than or equal to 12 undergoing those surgical procedures with invasive procedures, anticipated anesthesia greater than an hour. Place those SCDs prior to anesthesia, and that comes from the American College of Chest Guidelines 2012. Just one thing to point out to validate what Dr. Woller had said, the adult risk of thrombosis is 100 per 100,000 patients. Pediatric risk is 5 per 100,000 patients. And this is our VTE bundle kid. You may have seen Zoe Hamilton. She's our bundle mascot for Zero Harm. Each area has a flip chart, and it has each one of the hospital-acquired conditions listed. This is for venous thromboembolism. We want the assessment piece in there. A lot of the non-CVC can be altered by basic nursing care, maximizing mobility, placement of SCDs, and assessing for these risk factors, and then also for patients with the CVC, assessing and early detection of that clot so that it can be treated. So just a reminder for preventatives, for greater than 12 years, is there an SCD in place on your patient that requires one? Is that level of activity maximized? And assessing anticoagulation therapies. So we'd like to build into the bundle some critical thinking about when to stop anticoagulation, and we've had some incidences where it has not been stopped, and we've had bleeding in the OR as some serious safety events. So we'd like to really build in that critical thinking of stepping it down, and then certainly when to step it up if we're not meeting our milestones for our lab measures, such as our INR or anti-10A. So we just wanted to give great thanks to the VTE team. We have lots of folks helping us, and certainly Dr. Miller has talked about the IV team and their accolades, but also our VTE I just wanted to mention by name. We have Dr. Chris Miller is our physician leader. From my IV team, Westy Douglas has really led that CVC initiative. Roger Wilcox is the pharmacist on our team. He's helped us really establish and get our anticoagulation data. We started from scratch just looking at our reports that he had. Ernest Chan is our data person, and he's been amazing at getting our ICD-10 codes to us in a timely fashion to validate our anticoagulation data. And then we have Matt Iyer from the OR, who's taken an initiative and really embracing the pieces that we need to do in the OR. Mary Jo Grant is our pediatric nurse practitioner from Pediatric Critical Care Services. She's helped our team, as well as Dr. John Woods is one of our physician leads on the team. Erin Bennett is one of our fellows helping. She's going to help us with the care process model development over the next couple of years. And Brandon Clements is our nurse manager in Pediatric Critical Care Services, helping with the bundle. Erin Porter from Children's Medical Unit has helped us, and Carol Bollinger is our representative with the trauma and the surgical team, nurse practitioner there. So thank you so much to the team. Any questions?
So have any of you considered the potential use of thromboelastography in the evaluation of VTE risk?
Well, while acknowledging that my expertise tends more toward the adult population than the pediatric population, at least for understanding thrombosis risk in adults and varying populations, whether they be trauma or surgical or medical. TEG it provides uncertain feedback. Certainly you can assess an overall bleeding risk. However, how that can be interpreted clinically is less well defined. And likewise, there is a variance in the response from TEG results, and that relationship to clinical outcomes is tougher.
Thanks for the spectacular presentations. That was amazing. Dr. Miller, I'm curious about how you handle one metric in CVC population, and that is that the best way to prevent a VC-related thrombosis is not to put a CVC in the first place, or failing that, removing it promptly when it's no longer needed. Since your denominator metric is CVC days, do you have another way at which you're looking at the rate of use of the device itself and whether there's an opportunity to try to control that?
So I think that's the other important piece I think that we need to look at as well. You know, one of the other things we're following was patient days. But I think as I was talking to Dr. Woller before we started, the other piece of this is it's helping the central line associated bloodstream infection group is, I think, helping our group tremendously as well, because I think, as you mentioned, can we prevent this from happening at all? And so really it's going to be attention to, does the patient really need a PICC line? Do they, you know, and if they do need the PICC line, when can we get this thing out? So we're limiting how long it's actually. And I think the other piece that that oftentimes comes up is, as a physician, a nurse will call me and say, hey, I poked this kid like 15 times, they're a really hard stick, like how do I, can we get a PICC in the kid? And you're like, sure, sounds great. And then when you go to order it, you're like, well, if a single lumen is good, a triple lumen must be better. And we all know that the bigger the catheter, the more the risk for VTE. So I think a lot of it's going to also be around education of like, one, do we need the PICC line? Two, when can we get it out? And three, bigger isn't always better. So.
Any other questions? Yeah? Did I see? No? Well, my fellowship director died of a PE after a long flight from South America. So, like Karmella, I have also a colleague to remember. Any other comments? Yeah? Oh.
I know our V team had wondered, Dr. Woller was one of the authors of the MAGIC study, which is really a big study out there, Michigan appropriateness for prevention.
Correct.
And so we know that that's huge for the adult population, and in fact, we actually see we could probably have an algorithm for PICC line placement come out of that, as well as a standard order set. Is there efforts to do a pediatric MAGIC study?
Yeah.
And can you tell us anything about that?
Thanks. Well, the MAGIC initiative was really designed to apply a standardized approach to understanding best practice in an arena where limited data exists. And they used a RAND UCLA method to, in effect, provide clinical scenarios and then have putative experts in the field rank their and provide feedback on their approach to these individual cases. I think among the greatest outcomes of that publication is providing guidance surrounding standardizing an approach, just as you're doing here. When we think about the systematic adoption of a process, why measuring what you've got is always the first step. And so you are well on your way. Then using those data to look for opportunities. And I would highlight what you're doing already among your greater than or equal to 12-year-old patients, where we have perhaps a paradigm that more aligns with what we know about adults is great. So yeah, I do believe that the body of evidence surrounding VTE risk mitigation is less mature in pediatrics, that an approach similar to what we used in MAGIC would help advance the field and the understanding, and taking that one step further, as you are doing here, measuring outcome events and then looking for opportunities to intervene is the way to go.
Any last comments or questions? No? Well, thank you so much. I have learned so much today. I don't think we don't see too much of this in the ER, and we don't really talk about it much. So thank you to everyone. Join me in thanking our guests.